Hey there, this is Dr. Pawan, your surgery educator on Unacademy platform, and today I'm here to talk to you about the Dungeons and Dragons section, that is clinical situations in surgery explained. So let us begin my discussion. So we have the clinical scenario over here that there is a mother, Amanda, and she has brought to you her 3-year-old child, Matthew, who is having an undescended testes. So when the mother brought the child to you, you tried to palpate the testes, but you did not find any palpable testes in the inguinal canal. What is the next best step in the management of this particular patient? So here there is a mother who has brought the child to you, and the child has been brought to you. The child is having an undescended testes. You tried to palpate the testes, you were not able to do that. What is the next best step in the management of this particular patient? You will have to go for a laparoscopy. So please understand, the next best step in the management of this particular patient is laparoscopy. I hope you get this particular point. Now let us walk you through the management protocol of an undescended testes. So whenever you have a patient of an undescended testes, what you do is you try to palpate the testes in the inguinal canal. If you are able to do that, well and good. If at all you are not able to do that, then what you do, you basically go for a diagnostic laparoscopy. So please understand, this is in fact the investigation of choice for a diagnostic, for detecting an undescended testes. Okay, so this is an investigation of choice. It is a very important MCQ. You need to remember this. Now whenever you perform this, what you do, you basically follow a testicular artery. So in the abdomen you have a testicular artery. Now this, why do you follow a testicular artery? This is based on the simple rationale that wherever the organ will go, it will take the blood supply along with it. So wherever the testes will go, the testicular artery will follow, and that is why we go and we follow the testicular artery so that we can reach finally the testes. So once you follow the testicular artery, if at all the testicular artery is not given in the option, you can go for a vas deferens. You can obviously choose a vas deferens, but if at all both are given in the option, you have to go for a testicular artery. So once you follow the testicular artery, you can have 3 scenarios. The first scenario which you can have is that you went and you palpated, like you found the testes. If at all you found the testes, very good. Just do the further planning and bring the testes down to the scrotum and fix it, like as the Orchidopexy at 6 months to 1 year of age. You have to do that. But if at all, let's say the vessel is entering into the deep inguinal ring, then what you will have to do. So if at all the vessel is entering into the deep inguinal ring, it states that the testes has already entered into the deep inguinal ring. Here you will have to go in for a inguinal exploration. So here you will have to go for an inguinal exploration. Okay, you will have to go for an inguinal exploration. And lastly, if at all you have a blind-ended vessel, so it means that there was some or the other intrauterine accident, intrauterine torsion, and because of that, what has happened, you have got a atrophic testes. So this basically indicates that you have a atrophic testes. Okay, so this basically indicates that you have a atrophic testes. I hope you get this particular point. Okay, so this is how you will manage a patient of a undescended testes if at all you are not able to palpate that particular testes. Now, so here you had a patient who you did not palpate the testes. So what you did was you went ahead and you did a diagnostic laparoscopy. When you went and did a diagnostic laparoscopy, you found that the testes is actually present at the deep inguinal ring. Okay, so if at all the testes is present at the deep inguinal ring, what will you go for? What will you perform next? You will have to go in for a Orchidopexy. So please understand, this is something which you need to understand over here. Okay, so here you will have to go for an Orchidopexy. Now if you look at the clinical scenario, you will argue that the child is kind of 3 years age, and if at all you want to preserve the fertility, the best time to kind of go for an Orchidopexy is between 6 months to 1 year. And the child is already 3 years of age, then why should I kind of do the Orchidopexy? Why cannot do a orchidectomy? Orchidectomy is a wrong answer here. Why you cannot go for an orchidectomy? Because your testes do not only produce the sperms. The another kind of an importance of the another kind of value which the testes adds is a testosterone. So please understand, testosterone is another important thing which is actually produced by the testes. Okay, this testosterone is actually produced by the Leydig cells. So Leydig cells actually produce this testosterone. Okay, and this particular testosterone is important for us. So that is why you will have to go in for an Orchidopexy, because these Leydig cells are not destroyed if at all. Even if you have undescended testes, they are kind of resistant to the damage, and the testosterone levels are still normal, and that is why you have to go in for an Orchidopexy. I hope you get this particular point. When will you go in for an orchidectomy? If at all the patient comes to you in a post-pubertal age, then you will have to go in for a orchidectomy. Are you understanding my point? I hope you understand this particular point. Now, if I just ask you, is this particular Matthew, like this child who was at 3 years age, is he still at the risk of a testicular carcinoma? Is he? The answer is yes. Please understand, he's still at the risk of a testicular carcinoma. So let us kind of look at some good facts. So what are these facts? So let's say if at all somebody has a undescended testes, what is the risk of a testicular carcinoma? The risk of testicular carcinoma is 4 to 6 times as that of a general population. Okay, so if at all somebody has an undescended testes, he is at a risk of testicular carcinoma 4 to 6 times as that of a the general population. But if at all, let's say there is you have done an orchidopexy. Okay, so if you were kind of able to do an orchidopexy in this particular patient, still the patient will be at a risk, but the risk will be lesser. So this risk reduces to 2 to 4 times that of a general population, but it doesn't become 0. So the moral of the story is, if at all there is a patient who is having an undescended testes, he is at a risk of a testicular carcinoma around 4 to 6 times that of a general population. Please understand, it is 4 to 6 times. It is very important. Some of the guidebooks give it wrong. It is 4 to 6 times. Please understand this. If you do an orchidopexy, then what is going to happen? Then also the risk of testicular carcinoma is going to persist. The only thing is, it is going to be reduced. It is going to get reduced to 2 to 4 times. I hope you get this particular point. Now, let's fast forward 30 years later. This particular child, this poor Matthew, again comes to you. So you were the kind of a surgeon who did kind of a diagnostic laparoscopy on this. So he again comes to you and he says that I have a painless testicular swelling on the right side. So he complains that I have a painless testicular swelling on the right side. So what do you suspect in this particular patient? So what do you think? What you dreaded for has happened now. So here, no doubt the patient is suffering from a testicular carcinoma. What do you suspect? You suspect a testicular carcinoma here. Okay, so please understand, if at all this child comes to you 30 years later with a painless testicular swelling, what will you suspect? You will suspect that this particular child is suffering from a testicular carcinoma. Right. Now, okay, now it is obviously no brainer that this particular child is suffering from a testicular carcinoma. That is fine. But if I just ask you, what will be the next step in the management of this particular patient? What will you do? So will you go for a biopsy or will you go for an orchidectomy? Don't you need to confirm whether this particular patient is actually suffering from a testicular carcinoma or not? Don't you need to do that? So will you not go for a biopsy? The answer is no, you will not go for a biopsy. Biopsy is not the next step. Why biopsy is not the next step? Because, okay, so please understand, whenever you suspect a patient to be of a testicular carcinoma, you never ever go for a biopsy. Why you never ever go for a biopsy? Because this will facilitate the spread of a testicular carcinoma. Okay, it will facilitate the spread of the testicular carcinoma. It will facilitate the involvement of the scrotal skin, and ultimately it will facilitate the involvement of the inguinal group of lymph nodes, which you do not want. You do not want this to happen, and that is why you will not go for a biopsy, or you will have to go for an orchidectomy. Are you understand my point? You will have to go in for an orchidectomy. Now, do you need to do a tumor markers before you perform the surgery? So I did tell you that you will have to go for an high inguinal orchidectomy. So before you go for a high inguinal orchidectomy, I'm just trying to ask you, do you really need a tumor marker? Do you need a tumor marker? Now please understand, you can definitely do a tumor marker. There is nothing wrong in it. You can definitely do a tumor marker, but please understand, the tumor marker will only support your diagnosis, support the diagnosis that the patient is having a testicular carcinoma. This is all that is the use of a tumor marker before you are operating on these particular patients. Okay, the next question which I'm trying to ask you, are these considered in the staging of a testicular carcinoma? The answer is big No. Please understand. So whatever the tumor markers you perform before the surgery, the pre-operative tumor markers, they have absolutely no role in the staging of the testicular carcinoma. So you must be aware that the tumor markers are used as a part of a testicular carcinoma staging. That is true, but please understand, those tumor markers are the post-operative tumor markers. We will talk about that, but the pre-operative tumor markers, they have absolutely no role in the staging of a testicular carcinoma. Please understand this. It is very, very important. Now, let us revise a couple of more facts. So what are the more facts which you need to revise? So what is the most common testicular carcinoma in the infants? Okay, so these all are one-liners. Okay, so what I have put over here, all the three are the one-liners. So if I just ask you, what is the most common type of a testicular carcinoma in the infants? The answer is yolk sac tumor. Okay, so yolk sac tumor, that is the most common type of a testicular carcinoma in the infants. The most common type of a testicular carcinoma in the pre-pubertal age group, the answer is teratoma. Most common type of a testicular carcinoma in the pre-pubertal age group, it is a teratoma. The most common type of a testicular carcinoma in the adults, what is the most common type of a testicular carcinoma? It is seminoma. So it is basically between 3rd to 4th decade of life. This is basically a seminoma. I hope you get this particular point. In the infants, it is yolk sac tumor. In the pre-pubertal age group, it is teratoma. In the adults, it is seminoma. And if the question basically is trying to tell you more than 60 years, then the answer would be lymphoma. I hope you get this particular point. Now, again, a couple of more facts. So I did tell you that this particular Matthew, who came to you after 30 years, what was the presenting feature of this particular patient? He came to you with a painless testicular mass. Okay, so this is in fact the most common presenting feature. So if somebody asks you what is the most common presenting feature of a testicular carcinoma, the most common presenting feature of a testicular carcinoma is a painless testicular mass or a painless testicular swelling. But is this the only way in which this particular patient can come to you? The answer is no. The patients can come to you with a various ways. So patients can come to you with an acute epidermitis. Okay, please understand. Around 10% of the patients come to you with an acute epidermitis. Okay, so please understand. Or 10% of the patients may come to you as an acute epidermitis. Around 10 to 30% of the patients can come to you with metastasis. So metastasis can be present in 10 to 33% of the patients. This is interesting. 2% of the patients can come to you with gynecomastia. So gynecomastia, really? Okay, so which tumor, if I just ask you which testicular tumor has a propensity to present as a gynecomastia? Okay, if you're saying your answer is Leydig cell tumor, you are absolutely correct. Why? Just recap. What is Leydig cell? So what do Leydig cells produce? Leydig cells produce testosterone. Okay, so what do Leydig cells produce? Leydig cells produce testosterone, and because they are producing testosterone, what is going to happen? This testosterone is going to get converted into the estrogen via the enzyme aromatase. Okay, and because of this estrogen, we are going to get a gynecomastia. I hope you are able to understand this particular thing. Just connect the dots. Leydig cell, they usually produce testosterone. If at all there is a Leydig cell tumor, more amount of testosterone will be produced. If at all there is a more amount of testosterone, what is going to happen? It is going to get converted into estrogen by the enzyme aromatase, and because of this estrogen, we are going to have a gynecomastia. I hope you are able to understand this. Okay, and around 1 to 2% of the patients can also come to you with an infertility. So I hope you get this. These are the important kind of facts which you need to remember. So okay, so coming back to our patient, our poor Matthew, who came to us after 30 years and he had a painless testicular swelling. You advised the patient, okay, so let's go for an high inguinal orchidectomy, and he actually agreed to it. He went for an high inguinal orchidectomy. So once you kind of operated on this particular patient, this was the specimen which you got. Okay, so this was the specimen which you got. So what do you think is the diagnosis of this particular patient? Okay, so absolutely no brainer. The answer to this particular question is seminoma. Okay, now let me just spend a couple of minutes to tell you why is it a seminoma. So please understand, seminoma usually presents as a homogeneous kind of a tumor, which has a kind like the shape of the testes is still contained. So as you can see in this particular gross specimen, the shape of the testes is still maintained, and it is a homogeneous tumor. It has no kind of signs of necrosis, no signs of cystic lesion, nothing. It is a homogeneous tumor. That is why it is most probably a seminoma. Okay, so obviously the final report will come after the histopathology, but yes, on the gross examination, this is a characteristic feature of a seminoma. Now let us revise the other gross features, right? So what is this particular gross feature, what you're seeing in over here? So this is a patient of a choriocarcinoma. Okay, so this is a choriocarcinoma patient. So why is it a choriocarcinoma? In the choriocarcinoma, what you're basically seeing is that there are the regions of a hemorrhage and the necrosis. So are you able to appreciate this? This is a part where you have a hemorrhage and the necrosis in these particular parts, and that is a characteristic feature of a choriocarcinoma. So on the gross section, you get a hemorrhage and the necrosis. That is a characteristic feature of a choriocarcinoma. Now what about this? No brainer. This is a gross specimen of a teratoma, because what you're seeing basically, you're seeing a heterogeneous tumor which is having a solid component and a cystic component in it. Okay, so there is a tumor, a testicular tumor, which is having a solid and a cystic component in it. Definitely it is a teratoma. I hope you get this particular point. So I've just covered the 3 gross specimens related to the testicular carcinoma. Moving on, so you have diagnosed that our Matthew is suffering from seminoma. Okay, so Matthew, he has suffered from seminoma. Now what do you think is the next step in the management of this particular patient? So let me summarize the events till now. The patient came to you in the childhood. The patient came to you at 3 years of age with an undescended testes. You did an orchidopexy. You sent the patient back. The patient came again at 33 years and he had basically a painless testicular mass. You operated on this and it came out to be seminoma. What is the next step in the management of this particular patient? What is the next step? Very, very important. Now the role of the tumor markers is very, very big. Okay, please understand. So now what you need to do is you need to repeat the tumor markers. When will you repeat the tumor markers? I have got operated like this, but a patient has got operated today. Matthew, you operated today. When will you send the tumor markers? When will you send the tumor markers? Please understand, you will send the tumor markers 3 to 4 weeks after the orchidectomy. Okay, please understand this. You will send the tumor markers 3 to 4 weeks after the orchidectomy. Why? What is the reason for this? Because you will allow whatever the tumor markers were present before the surgery to die down to a bare minimum level. You will have to wait for the tumor markers to kind of die down, because every tumor marker has a half-life. So you will have to wait 3 to 4 times the half-life of that particular tumor marker. Okay, only then you will be able to say with certainty that if at all there is a raised tumor marker, is it because of the previous tumor which you had before the surgery, or is it because of a residual disease or a recurrence? So please understand, if the tumor markers are persistently elevated even after the 3 to 4 weeks after the orchidectomy, then it confirms that those tumor markers are elevated because of a residual disease or a recurrence. Are you understanding my point? I hope you get this. This is a very, very important thing. So residual disease means most probably it is a metastasis. I hope you get this particular point. Okay. Now, at the same time, you will also perform a CT abdomen and pelvis. Now, what is the rationale of performing a CT abdomen and pelvis in this? Please note, I'm not saying a CT chest. You will not perform a CT chest. You will just perform a CT abdominal pelvis. What is the rationale? Because we know we have to do this to look for a retroperitoneal nodes. Okay, so this is basically done to look for the retroperitoneal nodes. I hope you get this particular point. Very, very important. So post surgery, you will ask the patient to do 2 things. You will have ask the patient to go for a repeat tumor markers after 3 to 4 weeks, and you will ask the patient to go for a CT abdominal pelvis to look for the retroperitoneal nodes. Now, what are the features you get in the seminoma? Now this is important. Let's just revise the features which you get in the seminoma. So seminoma, you have PLAP positive. So this is placental alkaline phosphatase. That is a kind of a tumor marker which is elevated in the seminoma. That is a good thing. Another important thing which you can remember, this is a kind of added information for you. So please remember CD117, that is a c-KIT. So c-KIT, it is a marker of your seminoma. Please understand. CD117 or the c-KIT, this is positive in the patients of seminoma. Please understand this. Right. Then please understand beta HCG, it can be raised in around 15% of the patients. Beta HCG, though it is primarily a tumor marker of a choriocarcinoma, still it can be raised in around 15% of the patients with this particular seminoma. Okay, I hope you understand this. Now lastly, we have a alpha fetoprotein. So please understand, alpha fetoprotein is never ever elevated in seminoma. You need to understand this. You need to grill this into your mind. So even if you have a histopath report which says it is a clear-cut seminoma, it is a pure seminoma, but on the blood reports you are getting alpha fetoprotein is elevated, you will consider this to be a non-seminomatous germ cell tumor and you will treat the patient like that. Very, very important point. Alpha fetoprotein is never ever elevated in the patients of a pure seminoma. Please remember this. Beta HCG, yes, it can be elevated. In 15% of the patients it is elevated, but alpha fetoprotein, it is never ever elevated. Now what is an importance of this LDH? So please understand, LDH is something which helps in determining the prognosis. Okay, if at all the LDH is elevated, it is a marker of bulk disease. Now, what do you understand this marker of bulk disease? What do you understand by this? So bulk disease means that it is having a lot of lymph node enlargements or something like that. Okay, so it is indicative of the prognosis. So more the LDH, poorer is the prognosis. I hope you get this particular point. Now, let us revise a couple of more facts because we have just talked about the seminoma. Let us also have a visit to the other tumors. So we have an embryonal carcinoma, which in this all the tumor markers are actually elevated. So in the embryonal carcinomas, so if it does somebody ask you which is a kind of a tumor of the testes which has all the tumor markers elevated, the answer is embryonal carcinoma. Then in the choriocarcinoma, I just told you that beta HCG is elevated. In the yolk sac tumor, no brainer, alpha fetoprotein is elevated. And in the teratoma, so per se, if you just ask about the teratoma, there is no actual real tumor marker of the teratoma. You don't have that. But if at all you want to answer one, Please understand, alpha fetoprotein is the one which you will mark as a tumor marker of a teratoma. Okay, by per se it doesn't have any kind of a tumor marker, but yes, if at all you have to mark something, you do mark alpha fetoprotein. It is raised in around 30-40% of the patients of teratoma. Important. Now let us revise another fact. So I did tell you that we will have to wait for 3 to 4 times the half-life. So as you can see, the alpha fetoprotein, the half-life is 5 to 7 days. So what is the 3 to 4 times of this? It is around 3 to 4 weeks. So you'll have to wait for 3 to 4 weeks for this alpha fetoprotein, beta HCG and the LDH to die down to the normal level. So I hope you're understanding why are we repeating the tumor markers after 3 to 4 weeks. The reason is because if after the 3 to 4 weeks the tumor markers are still elevated, if at all there after 3 to 4 weeks the tumor markers are still elevated, it indicates that the patient is suffering from a metastasis. Okay, that indicates that the patient is suffering from a metastasis. But if at all the tumor markers have gone, it indicates that whatever the surgery you did, it was 100% curative. The tumor has completely vanished from the body. Okay, that is why we have to wait for 3 to 4 weeks before repeating the tumor markers. Now another important thing is patients who have choriocarcinoma. These patients can come to you with the signs of hyperthyroidism. Why? Because the alpha subunit of the human chorionic gonadotropin, this basically kind of mimics the TSH, okay, and it can stimulate the TSH receptors. I hope you get this particular point. This is an important thing, okay. So if at all they ask you, like one of the clinical features of a choriocarcinoma, it can be hyperthyroidism. Why? Because the alpha subunit of that is basically kind of having a molecular mimicry, or it is basically having affinity towards the TSH receptors, and it basically goes and stimulates the TSH receptors. So it's an MCQ point, just remember this. Choriocarcinoma patients can have hyperthyroidism, not because of raised TSH, because of the raised alpha subunit of beta, like of the human chorionic gonadotropin, which basically acts on the TSH receptors. Okay, now if the tumor markers are elevated post orchidectomy, I just told you, if at all you have done a orchidectomy, you repeat the tumor markers after 3 to 4 weeks. If the tumor markers are still elevated, what does it indicate? Okay, please understand, it is very, very important concept. If at all the tumor markers are elevated, it indicates that there is a metastatic lesion. It indicates that there is a metastatic lesion. I hope you understand this. Okay, it indicates that there is a metastatic lesion. Right. So if at all there is a metastatic lesion, you will have to start this particular patient on chemotherapy. So chemotherapy is something which you start on this particular patient. So yeah, I mean, we will talk about it, but yeah, if at all after the orchidectomy you repeat the tumor markers are elevated, what is the next step in the management? You go for a chemotherapy. I hope you get this. Right. Then what are the lymph nodes involvement in the testicular carcinoma? So if I just ask you, what are the lymph nodes involved in the testicular carcinoma? The answer is, what is the answer? It is a retroperitoneal para-aortic group of lymph nodes. Para-aortic lymph nodes. Why so? Because this goes down to the embryology. So this is an important concept again which you need to understand. Why is the lymphatic drainage of the testes going to the retroperitoneum? Because the testes actually arise from the retroperitoneum. They start their development from the retroperitoneum and then they come to line to the scrotum. And that is the reason why the lymphatics of the testes, they are going back to the retroperitoneum into the para-aortic lymph nodes. That is the reason. And this is something which you may not know, but yeah, please understand, there can be a crossover of the lymphatics. Okay, so the right side and the left side, can they cross over? The answer is yes, but they can cross over only in one direction. So please understand, the crossover can only be from the right to the left side. Okay, they cannot cross over from the left to the right side. So for example, if at all you have a right side testicular tumor, you will have a right side para-aortic group of lymph nodes involved, and ultimately you can end up having a left side para-aortic group lymph nodes involved. But if at all primarily if you have a left sided testicular tumor, you will never ever have a right sided para-aortic lymph nodes involved. Are you understanding my point? This is what I mean by a crossover from the right to the left. I hope you get this. So this slide is trying to tell you exactly the same thing, right? Now this brings us to the kind of TNM staging of the testicular tumor. So let me just walk you through it. So first let us talk about the PT0. PT0 is basically there is no evidence of a primary tumor, histologic scar in the testes. So what do you understand by this histologic scar in the testes? This is what is called as a burnt out primary. Burnt out primary. So this is a concept which you need to understand. If at all the testicular tumor was present inside the testes, it led to the metastasis, it led to whatnot, and ultimately that particular testicular tumor, it became vanished. It only a residual scar was present in the testes. So this is what is called as a burnt out primary. Here also you have to go in for a complete orchidectomy and even a retroperitoneal lymph node dissection and everything. I hope you get this particular point. Okay, this is what you understand by the histologic scar in the testes. Right. Now, what about the TIS? This is a carcinoma in situ. TIS basically is a carcinoma in situ. That is an intratubular germ cell neoplasm. That is fine. It is a carcinoma in situ. Now, if I just ask you which of the testicular tumors it doesn't arises from the TIS. So please understand, all the testicular tumors, they have a precursor lesion, that is a TIS, that is a intratubular germ cell neoplasia. But which testicular tumor doesn't arises from this? The answer is spermatocytic seminoma. Important MCQ. Which of the germ cell tumors doesn't arise from the intratubular intratubular germ cell neoplasia? It is spermatocytic seminoma. Do not forget this. Now, let us have about its PT1, PT2, PT3 and PT4. It is pretty simple, okay? Pretty simple, don't kind of freak out about this. So what is a PT1? Here you have a basically testicular tumor which is basically confined to the testes and the epididymis without any vascular or the lymphatic invasion. So it is a tumor which is confined to the testes and the epididymis without any vascular invasion. Okay, it may invade the tunica albuginea, but the tunica vaginalis is not involved. Okay, so tunica albuginea may be invaded, but the tunica vaginalis, it is not invaded. Okay, so this is about PT1. What about the PT2? Here everything will be kind of similar. Here also there is a tumor which is confined to the testes and the epididymis. Tunica albuginea, obviously it will be invaded, but here there can also be a vascular and a lymphatic invasion, and here there can also be an involvement of a tunica vaginalis. Okay, so here the tunica vaginalis can also be involved, and here there is a vascular and a lymphatic invasion. I hope you get this. PT1, PT2 exactly the same, only difference is in one you do not have a vascular and the lymphatic invasion, you do not have a tunica vaginalis involvement, but here in PT2 you do have a vascular and the lymphatic invasion, and you do have a tunica vaginalis involvement. I hope you get this. What about the PT3? Here you have a tumor which invades into the spermatic cord with or without vascular lymphatic invasion. So here you have a tumor which invades into the spermatic cord. So here basically there is a spermatic cord involvement. That is what is a PT3. What about the PT4? Here there is an involvement of a scrotum with or without the vascular and the lymphatic invasions. Forget about it. So involvement of the scrotum is a PT4. Pretty simple. I hope you got this. PT1, PT2, testes and the epididymis only. PT1, no vascular or the lymphatic invasion, no tunica vaginalis involvement. PT2, tunica vaginalis involvement present and lymphatic and the vascular invasion present. PT3 is spermatic cord involvement. PT4 is scrotum involvement. Okay, so done with the T. Now let us come back to the N staging. So what about N? N0 is there is no regional lymph node metastasis. Okay, N0 is no regional lymph node metastasis. N1 is metastasis of the lymph nodes but less than 2 centimeters mass, or multiple lymph nodes, none more than 2 centimeters. Okay, so here basically there is a lymph node enlargement with the size less than 2 centimeters. What about N2? Here again there is a metastasis with the size which is more than 2 centimeters but less than 5 centimeters. Okay, so between 2 to 5 centimeters if there is a lymph node enlargement, that is a PT, like N2. Okay, and what about the N3? Here there is a metastasis with the lymph nodes more than 5 centimeters in the greatest dimension. So more than 5 centimeters, it is N3. Pretty simple. Less than 2, 2 to 5, more than 5. Okay, N1 into N3. Now let's talk about the metastasis. So here, what is the M1 metastasis? M1 metastasis is there is a distant metastasis. Okay, right. Then M1 can be divided into M1A and M1B. This is important. What is M1A? So even if there is a non-regional lymph node involvement. Okay, so what do you understand by non-regional lymph node? So our primary, like the first training lymph node of the testicular carcinoma is para-aortic lymph node. So here what do you have? You have a non-regional lymph node involvement or the pulmonary metastasis. So that is considered as a M1A. What is the M1B? Any distant metastasis, so non-pulmonary visceral metastasis. Okay, so here what we consider as a non-pulmonary visceral metastasis. So any distant metastasis other than the non-regional lymph nodes or the lung. So it's one and the same thing, non-pulmonary visceral metastasis or any other metastasis which not includes the lung. Pretty simple, nothing great about it. Okay, so just imagine metastasis, distant metastasis, that's fine, nothing great about it. Okay, just forget about it. Then lastly, as we told you that the tumor markers are actually included as a part of a staging. So yes, tumor markers are included as a part of a staging, but what are these tumor markers? These are the post-operative tumor markers. Okay, so post-operative, after you have done an orchidectomy, after that what the tumor markers which you get, these are included as a part of a staging. So what are these kind of how they are used? So you can have a S1, S2 and S3. So you have 3 tumor markers. You have kind of an LDH, beta HCG, and alpha fetoprotein. So if at all you have a LDH, which is like the tumor marker of the level of the LDH is less than 1.5 times of the normal, it is considered as S1. If at all it is between 1.5 to 10 times of that of a normal, that is considered as S2. If it is more than 10 times of the normal, it is considered as an S3. So that is about the LDH. Then what about the beta HCG? If at all it is less than 5,000, it is considered S1. If at all it is 5 to 15,000, 5 to 50,000, it is considered as S2. And if it is more than 50,000, it is considered as S3. Then what about the alpha fetoprotein? If it all is less than 1000, it is considered S1. 1000 to 10,000 S2, more than 10,000 S3. So this is something which you need to remember. Just go through this particular part and just remember it. Okay, so this is how you basically use the tumor markers for the staging of a testicular tumor. Okay, so this is what we talked about. It's just the TNM staging, but the management of the testicular tumor, it is not dependent on that, not at all dependent on that. Okay, so what is the basis of the management which is dependent on? Now this is something which you do not need to remember by heart, not at all, at least not for the NEET PG. You do not need to remember it by heart, but this is how you basically do the kind of the grouping. So this is basically the stage grouping. I will not go into the details of it, but please understand this is how exactly we do it. It is based on the TNM staging only, but it kind of depends where you put what. Okay, so it is kind of very simple. Okay, I'll just walk you through it, but okay, it's not that much important for you. So even if you don't remember it, don't bother around it. Okay, so what do you have? You have 1A, 1B and 1S. Okay, so what is 1A and 1B? So 1A is basically PT1 and PT2 to 4. So everything will have N0, M0 and S0. So no tumor markers, no lymph nodes, no metastasis. But if at all you have a T1 or you have T2 to T4, that is stage 1A and stage 1B. What about 1S? In the 1S, what you are going to have? You are basically going to have a tumor markers elevated, but there is no lymph nodes and no metastasis. And you can have NET, but the tumor markers are elevated, but no lymph nodes, no metastasis. That is 1S. Understood? So that is about 1, nothing great about it. Now let us talk about the 2. 2 is basically involving the lymph nodes. So it's pretty simple. Any T can be there, but if at all there is a lymph node 1, lymph nodes N1, N2, N3. Pretty simple guys. Okay, if you just look at this particular table, it's not that difficult. The only thing is it is not needed at your particular level. Okay, that's it. I'll just walk you through it. N2A, N2B, N23, N2A, N1, NET, M0, NET, N0. Okay, right. Then what about P2, like 2A, 2B? Here there is a lymph node stations N2 involvement with NET, okay, NET and M0. So there is no metastasis. As you're able to see, there is absolutely no metastasis in here. Now, okay, and what about 3? So class stage 3. So stage 3 is stage 3A, stage 3B and stage 3C. So you can just go through it. It is a bit complex. If I just speak about it, it will create more complexity in you. But please understand, the only reason I'm not going into it because it is not needed for you at your NEET PG level. Okay, if you are interested, you can just go through it, but it is not actually needed. Okay, now okay, so this is how you basically stage the tumor. So first you read about the TNM staging, and then we had a look at the stage grouping of the testicular tumor. Now again, coming back to our Matthew, we forgot about Matthew. We were talking a lot about facts, so we forgot over Matthew. So let us recollect where was our Matthew. So we had Matthew who had come to you at 30 years of age with a painless testicular mass. You operated on the patient and you had a seminoma. Okay, and then what you did, you advised the patient, okay, go and get a tumor markers done, and you advised the patient that go and get a CT scan done. So when the patient came back, so and yeah, the histopathological specimen also came back. So the patient had a tumor which invades into the spermatic cord. So it was around a T3 tumor, and then the patient also came back with a kind of a CT scan report which showed around 4 centimeter lesion in the retroperitoneal lymph node. So there was N2 involvement. So there was T3 and N2 involvement. Okay, right. And you had also ordered an X-ray on this particular patient, and the X-ray showed this particular kind of a thing. So what do you have over here? So you have a characteristic cannonball metastasis. Okay, this is a characteristic cannonball mets. Okay, so you have a characteristic cannonball mets. Okay, so this is again a feature of a testicular tumors. So if at all you have this, okay, usually it is seen in kind of a choriocarcinoma. It is not that much common in the seminoma, but yes, you are having it over here, so why not? Just take it up. Okay, so just take it up. But it is usually seen in the choriocarcinoma. I have just scooched in over here because I just wanted to show you the pic. Please understand, it is much more common in the choriocarcinoma, not that common in the seminoma. But please understand, just take it for a consideration that here you have a M1 lesion. Okay, so you have a M1A lesion. Okay, so this is kind of a thing. And what about the tumor markers? So let's say the tumor markers were absolutely normal. So tumor markers were absolutely normal. Okay, let's take it back. Okay, then how do you manage this particular patient? Okay, so if at all you have this particular patient, how will you manage this particular patient? So if you just go back to this kind of a thing, so what is the patient having? Patient is having T3, N2 and kind of M1 and S0. So what is the answer to this particular question? So what is the patient is having? So right, so patient is in the category 3A. Okay, so patient is in the category 3A. Okay, so here is a M1A, there is NEN, that is N2. Okay, so patient is having a category 3A. So if you just talk about this, the patient is having a category 3A. So how will you manage a patient of a category 3A? You will have to go for the 3 cycles of BEP and 4 cycles of EP. Okay, so it is a bleomycin, etoposide and cisplatin. So this is what you will have to go for. This is a chemotherapy which you will go for. Now, is it strange? Is it strange that there is a patient of a seminoma and you are offering chemotherapy to this particular patient? Now, please understand, guys, for you, it is still the same. Seminoma is the one which basically melts with the radiotherapy and all those things. That is fine, that is good. But please understand, the recent management protocols, they do not say that, okay, you have to give only radiotherapy to the seminoma. It is not like that. It is not exactly like that. So this is again something which is a bit beyond your scope, but I thought you just know about this. Okay, so nowadays the management of a testicular tumor is not that simple. It is very, very difficult. Okay, so it has various kinds of combinations and there are various kind of treatment options available. So you explain the patient's them and then you and the patient decide them together depending on the various kind of depth of discussions. You don't need to go into all those things. You just need to understand what are the treatment options available with you. This is something important because this is also written in your love and belly. Okay, so please understand, if at all there is a stage 1 tumor, okay, so forget about what is the stage 1. I just showed you stage 1. You don't need to remember what is the stage 1, but yeah, just remember, if at all there is a stage 1 tumor, you have 3 options. You can either go for an observation. What do you mean by observation? You don't go for any further treatment. You just wait and watch. If at all the lymph nodes develop, if at all something develops, I will go and get treated. That is what is called as an observation or a surveillance. Okay, that is one thing. Or you can go for a chemotherapy. But please understand, here you go for a single agent chemotherapy. Here you go for a single agent chemotherapy. What is the single agent chemotherapy? It is called as a carboplatin. Carboplatin is the drug which you use in here. Okay, please understand, it is a carboplatin based single agent chemotherapy. You do not give a lot of chemotherapy, and ultimately, yes, definitely you might have to go for a radiotherapy. Please understand, this is we are talking about the seminoma. First we are discussing about the seminoma. So if at all there is a stage 1 tumor, you will go for an observation, or you will go for a chemotherapy, or you will go for a radiotherapy. If at all there is a stage 2 tumor, okay, then you may choose to go for a radiotherapy or a chemotherapy. Here you will have to go for the 3 cycles of BP and all those things. That is fine. And if at all there is a stage 3 tumor, it means that there is a distant metastasis, and we know what is the treatment for the distant metastasis. You will have to go for a chemotherapy. So I hope you understand this particular thing. Okay, I hope you understand this. Okay, don't go to any more details. Just remember this particular slide. These are the treatment options available. Depending on the patient, depending on the physician, you will manage this particular patient as the kind of a scenario says. Lastly, we are going to talk about the management of a non-seminomatous germ cell tumor. So how do you manage? So again, a non-seminomatous germ cell tumor can be stage 1, stage 2 or a stage 3. So how will you manage a stage 1 non-seminomatous germ cell tumor? You will have to go, the options which you have are, you can go for an observation, you can go for a chemotherapy, you can go for a RPLND. So what is this RPLND? This is called as a retroperitoneal lymph node dissection. So what is it called as a? It is called as a retroperitoneal lymph node dissection. This is what you will go for that. What about the stage 2? Again, you will have to go for a RPLND or a chemotherapy. Okay, and stage 3 you will have to go for a chemotherapy and the RPLND. But please understand, there is no role of a radiotherapy in the non-seminomatous germ cell tumor. Okay, there is absolutely no role of a radiotherapy in the non-seminomatous germ cell tumor. You will not go for a radiotherapy in the non-seminomatous germ cell tumor. I hope you get this particular point. Okay, so all you need to remember is, it is very, very complex. I've just tried to simplify it for you, but it is very, very superficial. It has lots and lots of details. If you actually learn how to manage a testicular tumor, it is way beyond your scope, not needed for you. Just remember these 2 particular things, you will be good to go. Lastly, let me just tell you about a couple of buzzwords which you might have heard about. So this is an important thing, because such kind of a detailed question has been already asked to you. So they had once asked you, what is the preferred treatment for a teratoma? That is what they had asked you. Okay, so please understand, the preferred treatment for the teratoma is excision, surgery. Why? Because please understand, teratoma is a radio resistant. It is a chemo resistant. It is not responding to chemotherapy. It is not responding to radiotherapy. Usually the non-seminomatous germ cell tumors, they do respond to chemotherapy, but teratoma, it doesn't respond to the chemotherapy. Please understand this particular point. Okay, so that is why there is something which is called as a growing teratoma syndrome. So let's say if at all there is a non-seminomatous germ cell tumor, the patient is having a retroperitoneal mets. So these retroperitoneal mets, if at all these retroperitoneal mets are teratoma, okay, so if at all these retroperitoneal mets are teratoma, so even if you give this particular patient chemotherapy, will they kind of get into control? They will not get into control. They will still continue to grow. So even if, let's say, the tumor markers were elevated and there was a retroperitoneal mets, you started the patient on a chemotherapy, but the size of the retroperitoneal metastasis, it kept on increasing. This is what is called as a growing teratoma syndrome. Okay, so then you will have to go in for a biopsy. If you confirm that it is a teratoma, you will have to go in for a surgery. Okay, that is fine. You will have to go for a retroperitoneal lymph node dissection. Okay, forget about that. The concept behind the growing teratoma syndrome is that teratoma is a chemo resistant, it is a radio resistant. That is why we have to go for a surgery in these particular patients. Okay, so this is all about, I wish to talk to you about the testicular tumors. It is a very, very vast topic. I've just tried to summarize few of the concepts for you. So now I'll just talk to you and I'll just summarize whatever we have talked today. Okay, so this will hopefully give you a gist of whatever I kind of thought of conveying to you. Okay, so yeah, so let's begin. So here we had a kind of a patient who had who was brought to you by his mother at the age of 3 years, and the patient had an undescended testes. You tried to palpate the testes, you were not able to palpate the testes. So what happened? You went ahead and did a diagnostic laparoscopy. In the diagnostic laparoscopy, what did you get? You got that there is a testes which is present at a deep inguinal. You somehow planned the surgery and you did a orchidopexy. All went okay, you sent the patient home. Why did you perform an orchidopexy? Because the patient had still not attained the puberty. You wanted the testosterone levels to be still present in this particular patient. That is the reason why you performed the orchidopexy and you sent the patient home. The patient again came back to you after 30 years. When he was 33 years age, he came back to you and he had a painless testicular mass. Okay, he had a painless testicular mass. Then what did you do? You went ahead and you did a high inguinal orchidectomy. By looking at the gross specimen, you thought that okay, so this patient is having a seminoma. You sent the patient sample for the histopathological examination, and meanwhile you asked the patient to do two things. What did you ask the patient to do? You asked the patient to repeat a CT scan after you asked the patient to do a CT scan of the abdominal pelvis, and you asked the patient to repeat the tumor markers after 3 to 4 weeks of the surgery. Okay, so the patient came back to you. The histopath report said that there is a seminoma which is involving the spermatic cord. Okay, then the CT scan report came back. The report says that the patient is having a 4 centimeter retroperitoneal lymph node metastasis, and then you also ordered an X-ray which showed a lung metastasis, and the tumor markers were, let's say, normal. So this basically concluded that the patient is having a stage 3A, and that is how you went ahead and did a chemotherapy in this particular patient. Okay, so this is the kind of a case scenario which we had. This is how you manage this particular patient. There are lots and lots of branchings and the different aspects of a testicular tumors. I hope I have tried to cover what I intended to cover. Thank you so much, guys. I hope this particular session added some value to your life. I hope you liked it, and thank you so much for joining with me. See ya. Bye.